Great. Well, I think in true spirit of these lightning talks, I'm pretty keen that we start now, and that we'll obviously finish at 12:30, because I know this is a busy time for many who will have joined today. And just like to welcome you all. There'll be some hardy perennials, and I suspect, looking at the squares, a number of new faces as well. So my name's David Byrne. I'm the Director of Newcastle Health Innovation Partners, our academic health science centre, and also Faculty Pro Vice Chancellor. It's a real pleasure to be able to have you all along for this lightning talk session, which has got the fantastic title of Diamonds Are Forever. The James Bond fans amongst you will I'll not be lost on you, and at least we don't have a Dr. No with us here in the form of John Paul Taylor. He's very much a doctor. Yes, he's the man who's going to run the show actually here, because in breaking from previous tradition of two speakers, we're going to go for a single speaker, which is John Paul, who's been intimately involved in what's called the Diamond Lewy project or program, and he's also going to show a short video as well. I'm unclear that there may be some family members who've had loved ones affected by DLB on this call and this meeting, and if there are, you're extremely welcome. I'm sure that John Paul will be trying to explain things in a way that is digestible for us all. So without any further ado from me, John Paul, thanks very much, and I'll hand it over to you to take it away.
Thanks, David. Everybody hear me okay? Excellent. All right, so let me just share screen. And again, David, if you're happy to
have signed up and then can't attend, and so they can watch it later. So I hope that is okay. From a Q&A point of view, could we ask that you put any questions into the chat, and we'll come around those in the 10 minutes that's left at the end of the talk and the session. Thank you. John Paul.
Great. So yeah, you can see the slides.
Absolutely, perfect.
Perfect. I'm afraid I'm no Sean Connery, but I'll try my best to do a reasonable presentation here. And as David has introduced, Diamonds Are Forever. This is an overview of the NIHR UK Diamond Lewy study, which was a major 5-year project from 2014 to 2019, and I suppose it's an example of a multi-organizational piece of work between our sponsor CNTW, as well as Newcastle University, University of Cambridge, as well as the Cambridgeshire and Peterborough NHS Trust. And I have to say, it's the organizations working together which has really led to the success of this overall study. So I'm going to take you through a little bit of a walk with regard to this this particular study. And I suppose the first thing to start off with is a little bit of the nomenclature in terms of Lewy body dementia and what I mean by Lewy body dementia. It's really an umbrella term which includes people who have got Parkinson's disease, who subsequently then develop dementia, or PDD, and also includes people who get dementia with Lewy bodies, DLB. And really the background to both of these conditions is the core neuropathology element of Lewy bodies, or Lewy body disease. Now, LBD is, as I say, is a condition which includes PDD and DLB, and the two conditions are overlapping in terms of the symptoms that people experience, but they are differentiated probably on the basis of the timing of the movement or Parkinson's symptoms relative to the cognitive or dementia symptoms. So for example, in Parkinson's disease dementia, the dementia starts 1 year or more after well-established Parkinson's disease, whereas in contrast in DLB, the dementia occurs before or concurrently with the Parkinsonism, or certainly within 1 year of the onset of the motor symptoms. Now, for the purposes of today's talk, whilst the Diamond Lewy program covers both DLB and PDD, most of what I'm going to be talking about is DLB. So what's one of the big problems with DLB? And that, I suppose, is the underdiagnosis and lack of systematic approach to the management. When you look at the brains of people who have died with dementia, up to a quarter of them have evidence of Lewy body disease. However, if you look at the diagnostic rates and prevalence in clinics, for example, and in research cohorts, it's much lower at 4 to 7%. And we don't know what the diagnostic rates are in routine clinical practice, for example, in the NHS. There's been many previous studies which have recognized that there is a lack of recognition of DLB and a more complex road to diagnosis. Furthermore, if you have LBD, you have a much lower quality of life compared to other dementias, and that's also true for caregivers as well. The other thing that we've discovered is that people who have got DLB have very poor outcomes. There's significant higher acute hospital resource usage in DLB compared to Alzheimer's. Furthermore, DLB survival is shorter from point of diagnosis compared to Alzheimer's. So this makes the condition hugely challenging. So this now leads on to the Diamond-Lewy program, which is the acronym of improving the diagnosis and management of neurodegenerative dementia of Lewy body type. You can see I struggled over that, hence Diamond is the perfect way to describe it. And this was a program which aimed to bring together brief assessments and management toolkits and assess the latter through a cluster randomized study. As I said in my introduction slide, it was a multi-organizational endeavor led by John O'Brien. So this is just a summary of the Diamond-Lewy program and its work packages. And as said, it constituted organizations within the northeast of England, as well as East Anglia. The very first point I want to make is that there was a very significant public patient involvement component to the Diamond-Lewy program. This involved a lay applicant being involved from the beginning when we did the grant, as well as also being a member of our study management group. We also had a PPI group supported by Ian McKeith and Claire Bamford, who met several times a year over the course of the 5 years of the study. And they inputted on the study materials, toolkit design, workshops, newsletter content, and other elements of the study. And I have to say, their contribution was central to the success of the overall study. Let's look first at the work package 1, which was really addressing the question is, how often is Lewy body dementia currently diagnosed and how is it managed? This was work which was led by John O'Brien, as well as our esteemed PVC, David Byrne, with the objectives of looking at the diagnostic rates and prevalence and care pathways for people with DLB and non-DLB dementia, as well as for Parkinson's disease dementia. Now, I'm really sort of titrating this down into what was an immense piece of work into just a couple of slides, but essentially it was a medical case notes review looking at the diagnosis of DLB compared to non-DLB dementias across a number of different memory services and NHS trusts, as well as movement disorders and neurology services. So what's the money slide? Well, overall, what we've seen is in the NHS, that the average prevalence of DLB was 4.6%. We can see that the prevalence in the northeast of England was higher at 5.6 compared to 3.3 in East Anglia. Now that might reflect certain historical elements, given that we have had a big focus in terms of LBD within the northeast. But I would draw your attention to the graph below. The variations between individual services was much higher. And this really points to individual clinician interest and expertise potentially in diagnosing LBD and DLB. And I think it really speaks to the fact that there is actually a marked variation in terms of what we do out there practically in terms of the NHS. What we found is that over half of DLB patients had a prior diagnosis of something else. Time to referral to DLB diagnosis was also longer compared to non-DLB dementia. We also seen that the number of tests, particularly structural imaging tests before final diagnosis, was higher in DLB compared to non-DLB, pointing towards the complexity of this particular condition in the pre-diagnostic phase. We also noted that DLB cases had more clinical contacts, both prior to diagnosis and then after diagnosis, again pointing towards the fact that this condition is complex. Our next question, led by Claire Bamford, was looking at what are the barriers and facilitators in diagnosing and managing LBD. Again, summarizing a huge piece of work, Claire conducted observations in clinic with focus groups and interviews with healthcare professionals and people living with LBD and their carers. Professionals reported, well, why improve LBD diagnosis, including DLB, unless the management differs, for example, from Alzheimer's? There was also a lack of awareness of the core symptoms of DLB, for example, and a lack of systematic inquiry after these symptoms, or indeed an approach to management. people living with LBD and their caregivers had limited knowledge of the condition or how to manage their symptoms. And they also faced challenges in terms of social contact, with social isolation, as well as also engaging with activities. And everybody reported back that there was a feeling of fragmentation of NHS services. Some people have been seen primarily within old age psychiatry, others within movement disorders, but perhaps a lack of access to physiotherapy, occupational therapy, speech and language, and so forth. So we thought, well, what's the next steps that we want to do? How can we improve the diagnosis of LBD? And this was work championed by Alan Thomas. This is a publication in regard to this, a development of assessment toolkits for improving the diagnosis of LBD. And this, as I say, was work led by Alan Thomas, published in the International Journal of Geriatric Psychiatry, really taking a look at a systemized approach to the diagnosis of DOB and PDD. This has been refined more recently, and if you want to actually find these materials, just type Diamond Lewy into your favorite search engine, and the Diamond Lewy website has all of the details. So what is the output? Well, this is an example of the assessment toolkit for DOB. And you can see it's a very sort of structured approach, taking the use of the diagnostic criteria and establish them within the toolkit in a very systemized way, covering, for example, the core clinical features, as well as also keying people in to think about what investigations and imaging they might want to conduct if they're thinking about DOB. There's also an assessment toolkit for PDD as well. Within the assessment toolkit are a number of validated questions to identify symptoms of, for example, DOB, cognitive fluctuations shown here, as well as REM sleep behavior disorder. There's also available toolkit videos on the website for training of individuals. Sorry, I'm one slide ahead, apologies. Showing here, I'm just showing the assessment of Parkinsonism. Many clinicians struggle with the assessment of the motor symptoms, and again, having a systemized approach, one can see that this is an easy way to determine the presence or absence of Parkinsonism. Just following on from that, as said, there is an assessment toolkit video on the website, which allows people to understand how to do and apply these particular assessments. It's also on YouTube as well. Okay. Now you may be asking, well, does this make any real world difference, introducing an assessment toolkit? Does it improve the diagnostic rates of LBD? Again, summarizing a huge amount of work, we looked back at those NHS services where we had assessed the prevalence of DOB. We took 4 of those services and we introduced the assessment toolkit. We encouraged people to use them in their day-to-day clinical practice. We then reevaluated the prevalence rates of DOB and noted that there was a 35% increase in the rate of DOB diagnosis. And indeed, in the northeast of England, the prevalence rates went up to 10%. So this provides tentative evidence to suggest that introductions of a very pragmatic assessment toolkit can make real world difference in terms of diagnosis of DOB. Okay, let's now explore management of LBD. And this was work which I led on with Ian McKeith. Now, LBD is a complex multi-system disease. People may experience cognitive difficulties, problems with their memory, thinking abilities, problems with hallucinations, delusions, depression, anxiety, apathy, lack of motivation, problems with their movements, Parkinsonism, falls, gait issues, a raft of autonomic symptoms, problems with controlling their blood pressure, urinary symptoms, constipation as examples. Also, people have problems with their sleep. I've mentioned REM sleep behavior disorder, but also insomnia, sleep fragmentation, restless legs. Overall, there is a heterogeneity in the range of symptoms that people experience, a range in the severity of symptoms between patients, and even within individual patients, there's a variation in the severity which fluctuates over time. And one of the big challenges we have in the management is that treating one symptom can lead to the worsening of another. So this can make it really difficult. So how do we deal with it? Well, we took a practical approach, a tripartite approach. we first of all asked what carers and patients felt was important in terms of management of symptoms. We looked at the evidence base as it exists in terms of pharmacological and non-pharmacological management. We identified that there was a large amount of gaps within our management, and for this, we brought in experts as part of a Delphi consensus panel to pull through evidence from related conditions such as Parkinson's disease and Alzheimer's to help inform how best to manage LBD. This is the output product, an overview summary sheet, symptom summary sheets, as well as detailed reference guidelines. This is just, I appreciate this is a bit small on your screen, but this can be blown up into an A0, for example, size to be put on a clinic wall. This is an example of the one-page summary sheet for the management of motor symptoms, whether DOB or PDD. There's also, as I say, the detailed LBD reference management guidelines, which contain the detailed statements which were ratified by our Delphi expert panel. We took this particular toolkit and we said, can we just check that this is fit for purpose within the NHS? So we piloted it within one NHS trust and tweaked it appropriately. We've also published a summary document with regard to the management toolkit in the Lancet Neurology. Now, again, to emphasize, all these materials are freely available via our Diamond Lewy website. Okay, so again, you may be asking, does this make any real world difference? And for this, we conducted a trial introducing this management toolkit into clinical services to see if it improves outcomes for patients and carers. This was work led by John O'Brien, myself, and Ian McKeith. Summarizing the overall study, it was an 18-month clustered design pragmatic trial, which included trusts across the northeast of England, as well as East Anglia. Services were randomized to either receive the management toolkit or continue with current practice. Of course, it's important to highlight that we could only encourage clinicians to use the management toolkit. We couldn't make it an absolute requirement that they had to do it. This study has been published now in Movement Disorders, but in essence, what we did is we assessed participants and their caregivers at baseline, 3 months and 6 months. This was done by research staff external to the study, unaware of what arm the subjects were in. And we had a raft of different measures in terms of cognitive measures, neuropsychiatric measures, Parkinsonism measures, as well as also global outcomes. We also wanted to see how carer measures were affected in terms of caregiver burden, anxiety, and depression. And we also conducted health economic analysis, although that's not part of today's presentation. This is just very briefly to show you the demographic table of those who were in the toolkit arm versus usual care. Overall, the groups were well matched. Perhaps there was a tendency for the toolkit arm to be slightly older and have slightly less neuropsychiatric symptoms and lower caregiver burden. Looking towards the main findings, it's really to report that in terms of the global outcomes, inclusion of the toolkit appeared to prevent worsening, and this was the clinician-rated global outcomes. This was also concurred by the caregivers as well. And in many respects, this is perhaps the best that we can hope for. Remember, a lot of our treatments are symptomatic treatments, so preventing or making it much less worse is a positive outcome. Positively, we also seen improvements in terms of the toolkit arm, in terms of caregiver burden, in terms of depression. So overall, this provides, in conclusion, tentative evidence for an introduction of a systemized management toolkit helps in terms of improving the overall outcomes for patients living with LBD as well as their caregivers. So nearly the final slide here, but in summary, there's an under-recognition and under-diagnosis of LBD, and in particular DOB, and this remains a significant challenge. The management is complex and difficult, but the Diamond Lewy program has produced a number of diamonds to help, including a structured diagnostic assessment toolkit and also holistic structured management toolkit. Now, diamonds are forever, at least for a while. This is really to say that, of course, we have to look at our management toolkit and update it as we get new evidence. And indeed, we're in the processes of currently updating it with a new systematic review as well as expert input. And finally, it's also to say that whilst this is all work which was done, within the UK, we're looking at an international perspective and exporting our Diamond Lewy kit to other jurisdictions and countries, and indeed is potentially going to be taken up in the US via the LBDA. So very much final slide to thank enormous numbers of people who've been involved in this study, and again to re-emphasize the multi-organizational working, which has really, I suppose, led to the success of this NIHR program study.
Thanks,
so thank you.
Thanks, John Paul. We've got about 4 minutes left for questions now, but I mean, that obviously there was a bit of a false start on the video there. There's a couple of questions come into the chat. Margaret Hens. Now, John Paul, do you want to answer this one, or do you want on how do you manage psychosis when Parkinson's medications exacerbate hallucinations? Is there an alternative treatment?
Oh goodness, this is very sort of drilling down to it indeed. I mean, I'm happy to take that one offline because it's often very specific to the individual. And as I showed you in the slides, when you improve one symptom, it may lead to a worsening of another. And often it is individualized to the patient, whether we consider some drugs such as antipsychotics or whether you use other drugs such as cholinesterase inhibitors or indeed memantine. And often we have to tune that to the particular person in question, but it's not an easy thing to deal with, and indeed it's perhaps one of the biggest challenges in LBD. But I'm very happy to sort of take that offline because I think, as I say, it's very nuanced to the individual. Yes,
I mean, the only thing I would say as well, sorry, John Paul, but I have to say this, it would be to ensure that the Parkinson's meds are simplified down to just levodopa, and that the concomitant meds are reviewed very stringently, particularly for anticholinergic effects, which could be exacerbating. There you are, John Paul, just to prove that I haven't forgotten my stuff.
Yeah, yeah. Well,
there's another question quickly. There's a lovely comment from Victoria Hewitt, who's basically saying they've got a patient on the unit with Lewy body dementia at end of life, and they're going to use the management toolkit today. Tom's come in, Tom Smulders. It's great to see you, Tom, and like this, and how likely are clinicians to take up the toolkits? Yeah, it's a really great question, actually. Is there a large opportunity cost, time cost, in other words, to them switching from their normal working practice?
Yeah, that's a very good question. And indeed, we have been exploring how do we implement this more and adopt the toolkits. I mean, via various educational forums, for example, we've been getting the message out to folks about the Diamond Lewy toolkit. I think the key thing to say about the management toolkit, and indeed the assessment toolkits for the diagnosis, is this is what people should be doing in their day-to-day clinical practice anyway. It's just a structured way of doing that. And indeed, what we're finding is people start to use the toolkits, and then after a month or two, they're freewheeling by themselves because it's embedded. It's part of their clinical practice. So I don't think there's a real opportunity cost with it, really, once you get to it.
John Paul, you've got two minutes for two questions. So quickly, Sharon Denley, if you've got a diagnosis of Parkinson's, I'm going to translate this into how likely is it that you will develop dementia associated with your Parkinson's, i.e. with a Lewy body-like substrate?
Okay, that should be a question to you, David. But I think
you answer it.
Yeah, I think the reality is that if you live long enough with Parkinson's, you're at increased risk of developing dementia. And indeed, up to 80% of people will develop dementia, unfortunately, if they've got Parkinson's disease. It does seem to be an older age phenomena, however, rather than
current age is the biggest risk.
Exactly.
And then in 30 seconds from Dermot Coughlin saying, how are GPs aware of Lewy body dementia?
That's a very good question again, and we are looking to do a piece of work which can actually, I suppose, raise the profile of LBD amongst primary care physicians, because I think that's a really important group who are perhaps neglected in this space.
Yeah, it's a really great question. Well, we didn't have that much time for questions, but the ones that came in, were real diamonds, and John Paul's managed to turn them around literally as the clocks clicked to 12:30, at least on my computer. So thanks to you all. In keeping with the spirit of these meetings, we're going to go for, you know, sticking rigidly to time, otherwise you won't come back in future. Thanks again to John Paul. That was a brilliant, really practically grounded and nicely explained, beautifully illustrated talk. Thanks very much, John Paul, and thanks to you all for your time.
Thank you, everyone.
See you all soon, hopefully, and take care. Bye now.